Have you ever found yourself, absent-mindedly scratching an itch? Maybe on your head.
hmm
And then you kind of realize you've been doing it. Maybe a bit too much.
Yeah, it happens. A totally common, almost unconscious thing for a lot of us.
Exactly. But what if that seemingly small habit, that little scratch, was actually hiding something much more complex underneath?
That's a really interesting way to frame it.
Well, today we're taking a deep dive into a condition you might not have heard of, trichotillomania.
Right.
We've got this really fascinating new study in front of us from a CAD dermatolovenereal. It's a multi-center retrospective study looking at 129
A
cases.
significant number, yeah.
Our goal here is basically to pull out the most important bits of knowledge from this research, give you a shortcut to, well, being well informed about this unique self-inflicted hair disorder.
And what's key about this study, I think, is that it's actually the largest case series on trichotillomania published so far.
Wow.
Yeah, so it gives us this really comprehensive look at, the clinical features, what factors are associated with it, and importantly, potential treatments. We're going to try and break down what it really is, who gets it, and how it can be managed.
Okay, let's start with the name itself. Trichotillomania. It's quite a mouthful. For someone hearing this for the very first time, what exactly are we talking about?
Simply put, trichotillomania is a self-inflicted traumatic hair disorder. The core characteristic is repetitive scalp rubbing or scratching.
Okay, rubbing or scratching.
Right. And while that might sound like just a simple habit, it consistently leads to, well, significant visible issues on the scalp. You might also hear other names for it.
Like,
Things like scratching pseudoalopecia, which kind of hints at hair loss from scratching, or lichen simplex chronicus of the
oh,
scalp.
okay. That last one sounds more like a skin condition description.
Exactly. It describes skin thickening from chronic scratching. Clinically, what dermatologists often see is hair shaft splitting and breakage, and this often results in single or sometimes multiple patches of alopecia. That's hair loss. So it's definitely not just a casual scratch. It causes measurable damage.
That paints a clearer picture of the physical side. So who typically gets this? Does the study show any patterns like age or gender?
It does. The study, remember, had 129 patients from 26 centers across 10 countries, so it's pretty broad.
Yeah, good data set.
And it found it predominantly affects middle-aged women. The mean age of patients was about 51.2 years. And females made up just over half, 52.7%.
Okay, middle-aged women primarily.
Primarily, yes. But what's interesting is the range. While the average onset age was around 49, the overall age range was huge, from 7 years old up to 87.
7. Wow, that young.
Yeah, and onset could be as early as 8, going up to 86. So it really spans almost the entire lifespan, even though the average points to middle age.
And how long does it usually last?
Well, the duration of the contagion, or the hair loss itself, averaged about 16.7 months. But again, big range, could go up to 140 months.
That's over 11 years.
Exactly. It really highlights how persistent and chronic this can be for some people.
Okay, so we have the physical signs, the demographics, but often there's more going on underneath. Did the study look into underlying factors, particularly any links to mental health?
Yes, absolutely. And this is where it gets really interesting, I think. They found a frequent and significant association with underlying mental health disorders.
Such a...
The most common one reported was anxiety. That affected about 19.4% of the patients in the study. Depression was next, at 9.3%.
Okay, nearly 1 in 5 with anxiety.
Right. But what's perhaps even more telling is the timing. Over 40% of patients reported experiencing significant distress triggers before they were even diagnosed with trichotillomania.
Before. So the distress came first.
In many cases, it seems so. It really underscores that when we see these physical symptoms, there's often this whole emotional landscape underneath that needs attention. The study specifically highlighted a strong link with anxiety. The odds ratio was 11, which is statistically very significant.
Wow, an odds ratio of 11, that's a very strong link. It does make you wonder about that chicken or egg thing, though, doesn't it? Does the distress trigger the scratching, or does having the condition worsen mental health? A vicious cycle, perhaps.
That's a great point, and it's likely complex, potentially a cycle for some. This study doesn't definitively answer that, but the high rate of distress before diagnosis strongly suggests psychological factors can be a trigger.
And what about other related conditions, like trichotillomania hair pulling? Is there a connection there?
Good question. So trichotillomania was observed in the same patients. Sometimes about 7.8% of cases had both.
Ah, okay.
However, the study explicitly stated that this didn't represent a statistically significant association in their analysis.
So they can occur together, but they aren't necessarily strongly linked in this data set.
Exactly. It implies that while mental health is clearly a factor, trichotillomania seems to be its own distinct thing, not just a variant of hair pulling. And importantly, the diagnosis shouldn't be missed just because someone doesn't fit a typical psychiatric profile. It really pushes for an individual assessment.
That makes sense. So thinking about the patient, what do they actually feel? What are the common symptoms they report? And where on the body does this usually happen?
The study was very clear on this. The absolute most common symptom, reported by a huge 87.6% of patients, was pruritus.
Itching.
Itching, exactly. After that, something called trichotillomania, which is basically a painful sensation on the scalp, affected just over half, 51.2%.
Pain from itching, essentially.
Or perhaps related to the inflammation from the scratching, yeah. Other things they saw clinically included erythema, which is redness, in about 40%. And lichenification, that skin thickening we mentioned, in about 34%.
Okay, and location, mostly the head.
Overwhelmingly the scalp. The most common spot was the vertex, the crown, in about 42.6%. Then the mid-scalp and the frontal area were also pretty common.
Anywhere else?
It's rare, but they did have one patient, just one, with eyebrow involvement. So less than 1%. This scalp is definitely the main focus.
Got it. So we know what it feels like and looks like. How do specialists actually diagnose this? Are there telltale signs they look for with, say, those magnifying tools they use?
Yes, exactly. That's where trichoscopy comes in, using a dermatoscope to look closely at the hair and scalp. In this study highlighted some really distinctive findings, almost like a fingerprint for trichotillomania.
Oh, interesting. Like what?
Well, most common things they saw under the scope were broken hairs in 93% of cases.
Okay, very common.
Then these things called brush-like ends or broom hairs. Imagine the end of a worn-out broom. That was seen in almost 87% of cases.
Broom hairs, okay.
And also longitudinal splits, sometimes called V hairs, where the hair shaft is split lengthwise. That was in nearly 80%. These are considered highly specific signs.
So seeing those broom hairs or V hairs is a strong indicator.
A very strong indicator. It helps differentiate it from other types of hair loss pretty effectively. They also noted things like scales around and between the follicles and sometimes white nodes on the hair shaft, indicating damage points.
And did they look deeper, like at tissue samples?
They did, yes. Histopathology, looking at biopsies under a microscope, was done on 76 patients. Common findings there were signs of inflammation, like inflammatory infiltrate and epidermal hyperplasia, which is that thickening of the skin layer again. It all confirms the body's response to that repeated rubbing and scratching.
Okay, so diagnosis relies on the patient's story, the visual signs, and these quite specific microscopic clues. Knowing all that, what does the study say about managing it? Is it easy to treat once you know what it is?
Not always easy, no. The management can actually be quite challenging, often frustrating for both the patient and the doctor.
Why is that?
Well, mainly because you have to break that cycle. The primary goal is to interrupt the pattern of itching and scratching or rubbing that just keeps the condition going.
Right, the itch-scratch cycle.
Exactly. According to the study, the most effective treatments reported were topical and intralesional corticosteroids, things to reduce inflammation and itching.
Any specific examples?
Yes, they mentioned clobetasol, 0.05% cream or ointment, applied once a day for usually less than 6 months. That particular approach showed a positive odds ratio for improvement, meaning it significantly increased the chances of things getting better.
Okay, so steroids are a key tool. Were other treatments used as well? Maybe things addressing the psychological side you mentioned?
Yes, absolutely. A whole range of things were reported, which kind of reflects the need for an individualized approach.
Makes sense.
So they saw anticonvulsants or antidepressants being used in about 19% of cases. Psychotherapy was used in 16%, and acetylcysteine, which is sometimes used for compulsive behaviors, in about 8.5%. And even topical minoxidil, the hair growth stimulant, in about 5%.
A real mix then. And what about the results? How well did people do with these treatments?
The outcomes were, I'd say, moderately encouraging. About half the patients, 49.6%, saw moderate clinical improvement.
Okay, nearly half.
And almost 30%, 29.4%, actually had good improvement.
Yeah.
So while it's challenging, positive results are definitely possible for a good number of people.
So pulling this all together, what's the big takeaway here for someone experiencing this or for the doctors treating them?
I think the crucial message from this study, especially given that strong link between psychiatric issues and a potentially tougher prognosis,
Right.
is the need for a multidisciplinary and really individualized approach. It's not just about the skin.
So dermatologists working with mental health professionals.
Exactly. Essential components like psychiatric care, psychotherapy, need to be considered right alongside the dermatological treatments like the steroids. It's about that holistic view, connecting the mind and body. That seems absolutely crucial for getting the best possible outcomes here. You have to address the underlying landscape, not just the visible damage.
We've certainly journeyed through the complexities of trichotillomania today. From what it is, who gets it, those surprising links to mental health, and how it's diagnosed and treated. It really shows how a seemingly simple act, like scratching, can become this complex condition needing a really thoughtful approach.
It really does. And connecting it to the bigger picture, I think it just underscores how vital it is to look beyond only the visible symptoms, to really consider the whole person, their overall well-being. This condition is a stark reminder of that deep interplay between our mental state and our physical health.
Absolutely. What really stands out to you as you reflect on our discussion, maybe it's those specific diagnostic clues like the broom hairs,
Those are definitely striking, yeah. Very helpful clinically.
or perhaps it's that emphasis on the multidisciplinary team. For you listening, as you think about this, consider how often maybe we overlook subtle, repetitive actions in ourselves or others that, over time could lead to real health impacts. What other everyday habits might have deeper, unseen consequences worth paying more attention to?
That's a powerful thought to leave with.
Thank you for joining us on this deep dive today. We really hope you feel more informed and maybe a little more intrigued by the hidden stories our bodies can sometimes tell.